one of the important concepts that we have introduced or are trying to spread into the lupus community is the concept of treat to target, concept that certainly in many diseases has been of paramount importance in changing the way to treat patients. And with the treat to target, we introduced the concept that the first target should be to reach remission in our lupus patient, and if it is not possible, at least low lupus disease activity. And we have not a good definition of these concepts. In the following years, we try to introduce definitions for both remission and low lupus disease activity. And this was a hard work, and actually there were still controversies and several groups put probably slightly different definitions. So first of all, I would like probably to start trying to remind which is nowadays the concept of remission and of low lupus disease activity, taking the advantage that we have in our panel several of those that participated in the definition of these concepts. I don't know if Manuel, you want probably to introduce the concept of remission, and Mandana, probably the concept of low lupus disease activity, because in some way also this concept came from the Asian Pacific area. So do you want to start, Mandana and Manuel?
Okay. Thanks, Ricard. Well, the idea in remission is that it should be the absence of disease activity. Originally, there were two proposals, remission on treatment and remission of treatment. The idea is we would like to have remission of treatment, but probably we're not going to be able to have it. Remission on treatment allows us to use some treatments, even glucocorticoids, but only 5 milligrams per day. We can use immunosuppressive drugs, but on maintenance dose, on stable doses. And they allow immunological activity, but the SLEDAI, the clinical SLEDAI should be 0. And they should include a physician global assessment, as we acknowledge that the SLEDAI is not perfect. I mean, for example, I don't know, if a patient has hemolytic anemia, the SLEDAI is going to be 0, but the patient is obviously active. So the idea is to improve the index, acknowledging that the index are not the best that we can have.
Thank you very much, Manuel. And maybe, Mandana, you can introduce the concept of low lupus disease activity.
Yes. So the lupus low disease activity operational definition differs a little from the current prevailing definition of remission, in that it allows a small amount of disease activity. So a SLEDAI that is 4 or less. The physician global needs to be less than or equal to 1 on a scale of 0 to 3, where 3 is the highest possible disease activity. And the highest allowable corticosteroid dose is 7.5 milligrams daily. Of course, as with the remission definition, use of antimalarials and immunosuppressants is allowed. So the two definitions are a little different, but in some ways quite close to one another. And we can perhaps talk about whether they are sufficiently different from one another to really comprise sequentially more stringent treatment goals. I think that remission definitely is a more stringent goal than low disease activity, but these are the current prevailing definitions.
So can I raise an issue?
Yes, of course, Betty.
I don't remember, maybe one of you remembers whether it was 2019, I think, that the FDA had a focus group of lupus patients. And they said that the 3 things that most diminish quality of life are pain, fatigue, and cognitive impairment. And those aren't really included in either of your definitions. And I think one of the things we need to do more of is listen to our patients and treat what interferes with our patients having what they consider a good quality of life.
Mm-hmm.
Thank you, Betty, because I wanted to introduce exactly this concept because Manuel and Mandana have been talking on these differences, SLEDAI and physician global assessment and the dosage of the drugs. But certainly I wanted to know what is the opinion of the patients that should receive therapies, and ideally they would like to be in remission, or ideally they would like to be cured, of course. And we have the opportunity to talk also with Lyndsy, which is a patient representative. I don't know if you can give Lyndsy your opinion on these ideas of remission, low lupus disease activity, if you know them and if they capture exactly what you want that these definitions or these concepts capture for the patient feelings.
So I think I agree with what's just been said. That really resonates with me in terms of kind of fatigue and pain being the things that actually really impacts on my day-to-day life. So I don't know if a combination of all of those things, if that's possible, would be the best way, because obviously the clinical stuff's really important, but yeah, from a day-to-day perspective, some ways of improving or measuring kind of things like fatigue is really, really, really important, and that's what kind of has the biggest impact, from my personal experience.
So if I might, Ricard, I think yes. we have to be careful here. You've got in your title here as LLDAS as or remission as a treat to target goal. And when we talk about treat to target, generally we are talking about the target that's necessary to allow us to stop or decrease anti-immunologic therapy. Now, what you're talking about now is very important, but it's got nothing to do with whether I'm going to lower the Imuran or the methotrexate or anything like that. So we have to be careful. And in LLDAS, for instance, you're talking about cognitive, Betty mentioned cognitive changes. LLDAS makes you at least say the patient doesn't have neuropsychological issues, so that if it's felt that the neuropsychological issues are due to lupus, then that's active lupus. If they're not due to lupus, those are type 2 symptoms, and those are very important symptoms. But I don't think we have to separate them in our treat to target definition,
I totally agree with you, but in the SLEDAI, neuropsychiatric lupus doesn't include cognitive impairment. So I think that we have to very much deal with the issues that patients are talking about. We also have to deal with the issues that, you don't feel as a patient, like accelerated cardiovascular disease, or until it's advanced kidney disease. And we have to, get people off of immunosuppressive therapy. So I agree with all of that. I think we have to have higher goals than this.
I agree, and sorry, Mandana, go ahead. Yes.
Sorry, I actually agree with everything that's been said, but just wanted to make a couple of comments. So when we were developing the lupus low disease activity state definition, we really had to be clear what construct or concept we were trying to capture. And in that regard, disease activity we were thinking of that in the way we have conventionally thought of it. So the aspects of disease that immune modulatory treatment might be able to address. And of course, encompassed in that definition is tapering and reduction of steroid dose, or achieving a threshold steroid dose. Having said that, we did in fact look at the relationship between LLDAS and a health-related quality of life measure, so the SF-36. And patients that have or are in a low disease activity state actually have better quality of life overall than those who are not. Now, that doesn't mean that those that are in LLDAS have their fatigue, pain, and cognitive impairment completely addressed, or those issues resolved. But I think there is certainly some correlation with better quality of life overall. And perhaps when we're looking at clinical trials, ultimately when we have drugs that are effective in managing both the type 1 and the type 2 symptoms, perhaps we should have other measures that directly tap into, or treatment targets that directly tap into the things that are particularly important to our patients. And ultimately, maybe we will be able to refine our definition of these treatment targets to include those type 2 symptoms when we have drugs that can address both type 1 and type 2 symptoms. So I think this whole space is a work in progress.
Hear, hear. I agree. And so I think you should retitle your title here, Ricard, LLDAS versus remission, as treat to target goals. A, for immunopathogenic mechanisms of lupus. B, type 2 symptoms of lupus, type 2 lupus symptoms, however you want to define that, because they're different goals. I would not go after a type 2 symptom with belimumab, but I would certainly do it for a type 1 for a type 1 lupus symptom or sign.
I agree. And a list of goals, of targets is on one side quality of life, and on the other side prevention of organ damage. And probably what we want is to cover with low lupus disease activity and remission both aspects, quality of life and prevention of organ damage, which is certainly very complicated. And maybe just to continue a little bit on the concept of prevention of organ damage, I think that, Murray, you have probably the best experience on how the concepts of remission and low lupus disease activity can prevent end-stage organ damage.
Well, it's clear
which one is the best, or if they are similar, probably is the concept that nowadays many people are defending.
Well, I mean, there's not, you can't, so far we have not had a good head-to-head LLDAS versus clinical remission study, because LLDAS includes clinical remission. If you have a SLEDAI of 0, a clinical SLEDAI of 0, and you're on 5 milligrams of prednisone, and so you qualify for remission, but you also qualify for LLDAS. So when you're doing an LLDAS study now, you're going to have to do LLDAS excluding remission. Then you'll be able to see whether LLDAS is really, and maybe Mandy can answer this already, whether LLDAS, the global LLDAS, which includes remission in it, and if you take those apart and look at LLDAS without remission in it, whether it's still a good predictor. I think that's an important question.
Yes, Murray. So to answer that, I guess it really depends on how you define remission. So the current working definition of remission, which is as described by Manuel, which is no clinical activity on the SLEDAI and a steroid dose of 5 milligrams or less,
right.
I think really it overlaps a lot with the definition of LLDAS.
Right.
So if you actually take out remission, take remission out of LLDAS rather, and look at the individuals who fulfill the criteria for LLDAS but not remission, there is actually a benefit in terms of reducing risks of flare and damage accrual for a variety of definitions of remission, in particular those that are very stringent, in other words, don't allow any activity and no clinical or serologic activity, and where the prednisolone dose is less than 5 milligram. But the distinction between the two is not so clear in terms of the current LLDAS definition, which I feel probably allows slightly bigger dose of prednisolone than what one might ultimately think is ideal in a definition of remission. And so maybe ultimately, when we do have a lot of very effective drugs, we will be able to get our patients completely off prednisolone. And in that situation, then definitely there is a significant difference between low disease activity and remission with a dose-response relationship, so greater protection against damage when you're in remission versus low disease activity, but low disease activity still conferring some protective association. But I think that's probably one of the most contentious areas at the moment, is whether our current definition of remission and low disease activity are sufficiently different from one another.
But where we wait for this, let's say, face-to-face comparison between remission and low lupus disease activity, following the recommendation of Murray. Nowadays, probably there is a suggestion that remission is more appropriate, treat to target goal in the newly diagnosed patients, that's more naive patients, and low lupus disease activity for patients who have a longer disease course. I would like also to know your opinion on these two potential uses of these two definitions. Mandana, do you agree that maybe low lupus disease activity is better for patients with a longer disease course?
Well, I actually think that really ultimately our goal should be remission, irrespective of what stage of disease our patients are in. And in fact, to be the devil's advocate, you might even argue that achieving remission is even more important in the long term, because we're looking at cumulative exposure to corticosteroids and the cumulative effects of persistent disease activity. So I'm not sure that I agree entirely. I think that at any stage in the disease, we should not be complacent and we should try and achieve remission. I think sometimes we fall into a pattern where we can become complacent when people have had long-standing disease and perhaps not try as hard as we should be to minimize medication burden and disease activity. So in my view, really, remission is the first and foremost goal. Its attainment perhaps not so feasible with the current therapeutic armamentarium. Maybe low disease activity is more attainable. We know that from data, but hopefully ultimately one day we can achieve remission in the majority of our patients.
I think this is...
I'd like to add something to this, which is, we're doing a study of patients in clinical remission plus or minus hydroxychloroquine, no steroids, and have been in that state for at least 3 years. And all the data and our, 1.5 year experience say that 5% of them are going to relapse. And so, preventing relapse is very important too, not just getting people down to the appropriate state, but figuring out how to, maintain people there while still decreasing the steroid level even further. So, Murray, this is why I'm not quitting yet. There's so much we still need to do.
I'd like to make a comment in relation to that. Actually, that's you raise a very, very interesting point, because we actually did a study where we looked at patients in the APLC cohort who had achieved low disease activity and what happened once treatment was further tapered. So we're talking about people who got down to a prednisolone dose of 7.5, in whom antimalarials, immunosuppressants were allowed, and where the steroids were then tapered further, or immunosuppressant doses were reduced, or immunosuppressive drugs were ceased. There was actually a very high rate of flare, and the risk of flare actually diminished if the individual was in a deeper state of remission. So those that had no serologic activity, for example, at the time that the treatment was tapered, were less likely to flare, but the risk of flare was still significant and substantial. So I think that it really emphasizes the point you made, in that it's all good and well to think about achieving target, but it's really important to keep our patients at target. And maybe the goal of actually getting people completely off steroids and off immunosuppressive treatments is not a feasible one just yet, because maybe we don't have drugs that are effective enough to get them to that really deep state of remission, or to even, dare I say, cure. But yeah, very important point raised.
Thank you very much, Mandana. I think that you put a good conclusion. Let's hope that one day we will have the cure for lupus, but in the meantime, let's try to achieve remission in most patients, and if not, at least low lupus disease activity with good health-related quality of life. Thank you very much, really, for all your inputs and very important comments.